PICC catheters. PICC line catheter usage has greatly increased over the past 10 to 15 years and is currently the most frequently used device in the home care setting. The catheter, which is usually inserted in the cephalic or basilic vein of the upper arm, may remain in place for several weeks to several months, barring any complications. It is suitable for both short and long-term therapies. There are two general types of PICC line catheters. They are open-end, which require heparin flushes, and the valved catheter, which only requires a saline flush. Common brands of PICC line catheters include the PICC, which is open-end, and the Solo and Gershon catheters, which are the valve type. Most PICC catheters are available in single, double, and triple lumen styles and are made of either silicone or polyurethane. While multiple therapies may indicate the need for double or triple lumens, in general, the fewer the lumens, the fewer the complications. The newer power PICC catheters that have recently taken the market by storm are made of polyurethane, as it tends to be a little stronger than the silicone catheter. The power devices are inserted to allow rapid injection of CT scan contrast dye at rates of up to 5 milliliters per second. The flushing procedure and dressing change procedure is the same for power devices as it is for the silicone catheters. One disadvantage of the polyurethane PICC is that it is a stiffer catheter, which may cause more discomfort. Also, an ethanol lock treatment should not be used with this type of catheter, as it can weaken and damage the polyurethane. There are several complications that can occur with PICC line catheters. The two most common are infection and occlusion. Infection can occur within the bloodstream or at the catheter exit site. In most cases, the catheter is removed and antibiotics are ordered to treat the infection. Good hand washing and strict aseptic technique are a must when working with the PICC catheter. A PICC line occlusion can occur when a fibrin sheath covers the internal end of the catheter, causing either a partial or complete occlusion. Blood backup into the catheter lumen with improper flushing can also precipitate a catheter occlusion. In some cases, a declotting agent may be used to restore patency in the catheter. If this is unsuccessful, the catheter must be replaced. Other complications include outward migration of the catheter and phlebitis along the course of the subclavian vein. The PICC catheter dressing change is a sterile procedure that is completed weekly and is needed by a trained RN. The extension and cap are also changed at this time. If gauze is used under the transparent dressing, it must be changed after 48 hours. There are several types of needleless caps available for use. With most catheters, it is best to use the positive pressure cap, as this exerts a continual forward pressure of the flush solution into the catheter. It is extremely important that the catheter not be clamped, as this disrupts the positive pressure function of the cap. One exception, changing the extension on an open-end catheter. The flush should be administered using a push-pause motion, leaving about 0.5 milliliters of solution in the syringe. Protocols for flush amounts vary, but in general, 10 milliliters of saline should be used before and after medications to clear the medication from the catheter. 20 milliliters of saline should be used after parenteral nutrition infusions, chemotherapy, and blood draws. If the catheter is open-ended, it will need a final flush with 10 unit per milliliter heparin.